Welcome to the Health Wealth Podcast and Radio Show with Forbes author and contributor Dr. Josh Luke, America's Healthcare Affordability Authority. Visit drjoshluke.com for information on speaking appearances and other resources.
He's gone from a career in sports marketing, working with the likes of Mark McGwire and NBA superstars, to a 10-year run as a hospital CEO. Now he's on a quest as a warrior against greed in healthcare, as a consumer advocate and best-selling author. Today, I talked to Dr. Josh Luke about his new book, Health Wealth, 9 Steps to Financial Recovery, on this, the premiere episode of Managed Care TV. Dr. Josh Luke, welcome to Managed Care TV.
Thanks for having me. Excited to be here.
Absolutely. This is just as exciting for me. I have been pouring through your book. I have to admit that I have not completed it yet, but what I got in the first few chapters is intriguing me. And, why don't we kick off the program talking about this announcement last week by Warren Buffett and the Amazon folks. And, I found it interesting that in your book, you actually mention Warren Buffett. You quote him in the book saying, the real problem is healthcare. He says that healthcare was 5% of the GDP, and now it's about 17%. He went on to state that medical costs are the tapeworm of American economic competitiveness. So what was going through your mind as you have that in your book, and then he comes out and makes this announcement?
Yeah, thanks for mentioning that. Health Wealth is healthcare bankrupting your business, 9 Steps to Financial Recovery. Here's a copy of the cover of it. It launched in January 18th, and it went right to number 1 on Amazon's new release list, and also a multiple category bestseller. So it's been really a hot topic. And since then, actually, it got even hotter, because within a week, Apple announced that they'd partnered with a number of major health systems nationwide to put our electronic medical record in our own hands, finally, which should have happened years ago, right? Isn't it ironic that we can't get access to our own electronic medical record? We actually have to ask permission and then pay for it and then be told we'll have to wait a few days most of the time, and all along we're being made to feel guilty as if we're putting a burden on the hospital for requesting that information. I think those days need to come to an end, and I think Congress is probably pushing for that pretty aggressively. So Apple made their announcement. Within a week of Apple's announcement, Amazon, JP Morgan, Berkshire Hathaway come out and say, hey, we're going to blow up our whole insurance model and start over. And what's ironic about that is 2 things. I mentioned them in my book, which had come out before that. Warren Buffett used the same quote that he had used 6 months earlier at his shareholder meeting about healthcare being the tapeworm of the American financial system. And it was very rewarding for me to hear that. So that's the first thing that I thought was a little ironic. The other thing that was ironic is the second half of 2017, I would get questioned a lot about, hey, Josh, how do we stop this locomotive that is hospital industry, lack of transparency that keeps driving cost up, and therefore insurers have to charge more. And every year there's just an annual premium increase for mid-market, Fortune 500 companies, even small businesses. And the answer I gave, and if you read my last book, which was called Execute, a former hospital CEO tells all on what's wrong with American healthcare, there's 2 chapters about big EMR in hospitals, big electronic medical record companies that control the whole industry. They're so big that when I was a hospital CEO, I was a hospital CEO for 4 different companies, 4 different hospitals. They told me at all 4 steps of the way, none of my hospitals were big enough for them to even waste their time with. And they really wagged the dog at these big hospitals. And so let me just close this answer by saying this. If the Affordable Care Act and everything that follows it is about value-based care and us taking care of ourselves at home, realizing that the largest expense in the model is if we have to go to the hospital, which in the model of the future is a sign of failure of the system, and the people controlling technology for us to care for ourselves are hospitals who have no incentive whatsoever for us to be well and at home. because they only get paid when our head's in their bed, and big EMR companies who only get paid by the hospitals who have no incentive, then who is it that's going to push technology into the home? And you know what my answer was for most of 2017? There's about 6 technology companies internationally that can trump this problem of hospitals and big EMR. And the exciting thing is that in January of 2018, 2 of them came out and said, we're going to make our move. And I'm pretty sure you can expect to hear something from Microsoft and Google/Alphabet in the near future as well.
So why all this greed? I mean, where does this stem from? I know reading your book, are we kind of, is the sun setting on the fee-for-service model? Has it already set? I know that there's the value care initiatives. I mean, where are we at right now as far as that's concerned?
Great question. Logic would tell you that the fee-for-service free-for-all, which is the name I gave it years ago, because it really is a free-for-all with no checks and balances. The fee-for-service free-for-all should have come to an end about 2012, right after the Affordable Care Act launched, Obamacare, right? The problem is, let's go back to my prior answer. Hospitals are in control, and they have no incentive to transfer the power away from themselves. They've always been the king of the space, right? So they drug their feet and drug their feet and drug their feet. And it was about 2015 or 16 before so many of these penalty programs started to add up that it actually started to have some financial impact on the hospitals, and they started to make the right moves or say the right things. I remember when I was first the vice president of post-acute services for a big health system in Los Angeles County back in 2013. I'd have people call me from all over the country and say, hey, I have the same title as you do, but they really don't want me to do anything. They just want to tell people that they're converting to value-based care. I would get that call all the time after I founded the National Readmission Prevention Collaborative, and it was largely true. Think about this. Readmission prevention and readmission penalties for hospitals was one of the programs that was introduced from Obamacare. So people would come to me after I founded this not-for-profit collaborative on readmissions and say, hey, I have this great product to prevent readmissions to hospitals. Can you introduce me to some CEOs? And essentially I said to them, hey, so here's your pitch, right? You pay the technology guy 10 grand a month and he'll keep heads out of your beds. The problem is they still get paid for heads and beds. So how's that pitch going to go? Not very well. So that's a real polarizing example of why this slow trek from fee-for-service to value-based care has taken place. But to your point, it takes an Apple, it takes an Amazon, JP Morgan, Berkshire Hathaway to say, we'll end the madness. We're declaring the tipping point. We are declaring the tipping point that healthcare is no longer affordable or sustainable. The hyperinflation is 10 to 15% annually. We can't do it anymore. And one more company that's top 10 internationally, but not a tech company, made an announcement in early February 2018. Disney said, hey, we're blowing up the system. We're starting over down in Florida. And you can expect the same announcement here in Orange County where I live and throughout the country if it works out.
So what do you think the game plan is to start things off with the likes of Warren Buffett and Jeff Bezos? What is their going to be their method in to break into this business? Is it going to be acquisition? Is it going to be organic? Where do you think? Look into the crystal ball for me.
Sure, and that's what I do as a healthcare futurist, and you can only imagine I've been doing nonstop interviews for about a month. Not just, as soon as my book launch ended, boom, Apple's announcement, Amazon's announcement. So I've been literally doing 2 or 3 hours of interviews a day and getting that very same question. So the answer is absolutely not acquisition, because the current model is the problem. And so there are so many simple things that not only can they do, but are already being done. And let me give you an example. If you look at the recommendations for how often somebody, a 45-year-old like me, is supposed to get a well visit, the debate is it 2 years or is it every 3 years? Most companies are now requiring you to do an annual well visit, which is a costly expense, right? So right off the bat there's a lot of stats that show companies can save anywhere from 2 to 4% of their overall spend by just using the recommendations that already exist. Remember, though, the insurer is not incentivized to give their client, corporate Fortune 500 mid-market company, that type of advice, because the insurer makes more money when more money is spent, and they can give you that annual increase each year. So number one, let's just use logic. I like to say 2 or 3 things. Number one, you and me and everybody else need to become an EHC, an engaged healthcare consumer. We shop when we buy for a car. We shop when we buy a house, neighborhoods, bedrooms, cost, all those things. Why don't we do it for healthcare? I'll tell you why we don't do it for healthcare. The myth that hospitals spread for years. Your insurance will pay for it. That's a myth and it's a lie. When you pick the quote unquote better hospital that's 60% more expensive because you're told don't worry about your cost, your insurance will pay for it. What actually happens is all your colleagues at work also pick that better hospital. And at the end of the year, because your employer had to pay 60% more for all of your procedures, they get a 10 to 15% increase on their annual premiums. They pass that on to you. Now they roll over to the high deductible plan. But let me tell you about the high deductible plan. It's not necessarily just cost shifting to you. What it's doing is it should be motivating you to become an EHC, an engaged healthcare consumer. And there's kind of a 3-point plan for becoming an EHC. When you become an EHC, shop for doctors, shop for procedures, hospitals when you
I'm a
go
small
there.
employer.
Engage in pharmaceutical purchasing. When you do those things, it creates competition. Competition will drive costs down for your employer, number one, and it will force hospitals to be transparent about their prices, which they aren't at present.
So is that what you feel is going to happen with Amazon and Disney? They're going to force competition, which is going to force the other insurers to drive the cost down, or what's the game plan there?
Well, I think if you were to create the model from scratch and forget about the last 50 years of the hospital industry, you probably wouldn't even engage the hospitals in the conversation, quite frankly, because they're the last resort. But because we're so programmed that hospitals are at the center of this universe, what you're going to need to do with these progressive companies, and I emailed a copy of Health Wealth out to each of the 3 people with those companies that are strategizing, and they were the first to say, we don't have a plan yet. We're not sure what our plan is. We just know that the hyperinflation has to stop and it's unsustainable. So there's 3 P's to a successful, cost-efficient healthcare strategy. Number 1 is have a plan. Number 2 is focus on preventative medicine, and number 3 is focus on personalized medicine. Let's be more specific. You can do DNA testing, full genome sequencing. It's now under $1,000 for a partial sequence. It's under $300. It'll tell you pharmacogenetics, which medications work for you and which ones don't. It will tell me different meds that work for me and different meds that won't work for me. That's an easy start.
So tell me then, what's going to be the difference in these new plans that are going to come forth, or the healthcare model from Warren Buffett versus companies that already self-insure, like Motorola and IBM?
It's completely different.
Okay.
It's a completely different scenario. They have nothing in common. They're going to start from living healthy.
Okay.
They're going to realize that the hospital is the last resort, and we don't want to get any advice or input from the hospitals. They are going to force competition, so the hospital who used to be able to strong-arm them no longer can. And I've heard from some of the top hospitals in the country, they say, oh, but they have to negotiate with us. And you know what my response is? Hey, Providence, Dignity, Atrium Health, Ascension, they have a hospital, Kaiser, right down the street from you. Don't be ignorant. They can walk away from you in a heartbeat. It's time for you to be transparent. When there's more than one hospital in town, competition exists.
Right.
We, as corporate America and as engaged healthcare consumers, have to force competition. I tell this story in my book. I tell it from the stage when I public speak. You walk into a hospital and ask them for their prices, and they look around like, what do you mean? We don't have those. Less than 20% of hospitals will share their prices with you. What other business in America, here's a question for your viewers and listeners, what other business in America can you not get the cost of goods or services before you're required to purchase or acquire? Ironically, in real estate and finance, not only is that not the case, but they are required by law to provide it to you in writing.
You know, it's kind of like the buying a new car scenario. Just tell me how much the car costs. Don't tell me don't ask me what I want my monthly payment to be. That's essentially the same line of thinking in the hospitals. I mean, they're just so used to calling the shots.
Yeah. You know, so it's interesting. My new website, health-wealth.com, it has a loss assessment if your company is looking to see how much wasteful healthcare spending you have, and I can guarantee you there's some. We have that we're going to launch the 9 audio steps to financial recovery by the end of February. We're also launching in September, Health Wealth is Healthcare Bankrupting Your Family. 7 steps to save $7,000. And that's going to be awesome because now it's going to be consistent with my presentation when I speak, which is, hey, I'm going to tell you 4 or 5 things you can do to save money tomorrow. And that ultimately is going to help your employer save, which is ultimately going to drive down costs through competition. But your question about how does the new model compare to these similar models we've seen, it doesn't look anything like it. They're going to start from square one and say, how can we engage our employers to live healthy? How can we create competition amongst hospitals? How can we go to a direct primary care physician model where instead of taking, so if you haven't heard of DPC, your clients, direct primary care is one of the most quickest emerging decisions your employer can make. Instead of taking, let's say they spend $10 million a year on healthcare costs, your organization, okay? Now, what we're going to do this year is we're going to take $4 million of that and still contract with Cigna or Blue Cross, okay, Blue Shield. But we're going to take another $4 million and we're going to find a local primary care clinic plus specialist that will give us carte blanche, walk in anytime for all of our employees and family members at their multiple local clinics. And after hours, if they don't have an urgent care, guaranteed 24-hour physician on call. Guarantee you, your employees will love this, right? They will love it. And it's a fixed cost for the organization. So when you stop and think about direct primary care, you go, hey, that kind of sounds like concierge medicine. And for those that don't know what concierge medicine is, in countries with socialized medicine and in small pockets in America where people don't want to deal with the bureaucracy that is health insurance, they say, hey, here's $8,000 a year. I'm gonna get access to this primary care clinic anytime I want. It's kind of for the well-to-do. DPC is not for the well-to-do, it's for the smart-to-do. The companies that say, hey, I can get direct access anytime from this major clinic in my town, why wouldn't I do it? And if you do the math, I gave $4 million to BCBS or Cigna. I gave $4 million as a fixed cost to this local group who's going to love the fact that they have guaranteed income of $4 million a year, right? And now you have $2 million of wiggle room to pay for the other components of your health care, and hopefully $1 million of that is just wiggle room, margin for error, if you will, hopefully profit margin. But what all of this leads to when you look at a direct primary care model is I want you to think about this. Life insurance and car insurance, those are catastrophic insurances. Why is health insurance not just catastrophic? Why is it all inclusive? And that's the problem, is when you separate into direct primary care, you're controlling controllable costs and you're doing it so much better than you would in the traditional model.
I'm 25 employees. My insurance rates have gone up probably by 10% at least in the last 3 years, and I'm fed up with it. And I know that's what your book, Health Wealth, is all about, is kind of talking to business owners. And we have our offices in a medical building. We have several doctors here, family practice doctors. Would it behoove me to go to them and say, hey, look, could we work out an arrangement? I'll let you see all of my employees, and it's convenient, it's here on site, it's a separate office. Is that the type of thing that you're advocating through this DPC?
Yeah, so in my book, 9 Steps to Health Wealth, 9 Steps to Financial Recovery, just giving you kind of a 120-second without doing the research, which is the most important part. The first thing I would say is look at alternative insurance models like Sedera Health, where they are offering telehealth, remote monitoring, immediate walk-in access. I would look at a direct primary care model. If normally for a company your size, DPC wouldn't be an option, but when you look at your overall spending and you're in the parking lot with a doctor who might have multiple specialists in their office, and you can take a fixed cost, and what we do is analyze what percentage of your current spend is going toward primary care, and you'd be alarmed to find out you could save significantly if you walked across the street to that doctor and offered him 40 or 50% or her of what you're currently spending for that guaranteed income. Remember, doctors are business people too.
Sure.
You're guaranteeing them a certain amount of income a year. They're going to be all over it.
So, the thing I love about your book is you are so passionate and you are so fed up with what we've, I mean, there's no other way to say it. I mean, I love the spirit that you drive forth in this book because you've been you've been there, you've done that. You've seen it on the hospital side where the spending is outrageous, and you've seen it on your personal side. I love the part where you talk about, your COBRA and having to make that decision, which that's attractive to no one that I know.
Yeah. Hey, you're unemployed. You get to pay for this yourself, and it's irresponsible spending, but do it. Yeah, $2,000 a month or whatever.
Exactly. One of the other avenues I just wanted to discuss with you that we talked about before we agreed to have you on the show is the emerging co-op model, where you've got
Sure.
these organizations. I know there's a lot of religious based of co-ops. Talk to me about a co-op. What are the advantages and disadvantages of an employer actually looking to go the co-op route?
So I told a story to my students. I teach at USC in public policy, and I told a story before I posted it to LinkedIn and Forbes, because I write for LinkedIn and Forbes.com. And I always shared it with my students to get their input and also to get some free copy editing. And I told them a story of this one patient one day who I heard him say he couldn't afford it, which is fine. That's what we did. I was there for the mission, not for the money. And then I went to the cafeteria, and we had a great cafeteria at that hospital. And I couldn't help but notice that him and his two daughters were in line. And I was in line behind him, being patient. I never liked to be the CEO that cut in line. And when he opened his wallet to pay in front of me, I saw at least $1,000 in hundreds in his wallet, which isn't all that uncommon, okay, in that territory, because a lot of those folks are working for cash.
Right.
But here's what dawned upon me. If I said to him, hey, great news, President Obama just passed legislation that gives you and all your family insurance, it's only going to cost you $450 a month. Do you know what he would have said? I'm coming to your emergency department.
I'm getting it
where
free.
It's free.
Yeah.
So when they undid the mandate, Trump administration undid the mandate. Now you're going back to, and an article even in this morning, early February 2018, said Obamacare enrollees this year down 3 million from last year. Why? Because the people that didn't want it to start with said, I don't have to have it anymore.
Right.
And that's just common sense, if you ask me.
Sure.
So what about these co-ops? The co-ops are now more in play because you as a small business owner, right? And even if you're a mid-sized business owner, when you say, hey, we're going to have a meeting and offer 6 options this year. If you're a Christian, we're going to offer a Christian co-op, and we're going to fund $200 a month. We're just going to pay it to you via salary. That's up to you. If there's co-ops that aren't Christian, I just in the book, I think we talk about there's a new Jewish co-op, healthcare co-op that's coming up. There's all these what I call alternative insurance models. And so the answer to your question is, are they legit? Yes, but there's no guarantee that your expenses will be paid. So in most of them, you have to pay up front and then ask for reimbursement. You have to be an active participant in the religion or in the organization. You can't just sign up and say I'm a Christian and sign up for a Christian co-op. They want you to walk the walk.
Fantastic. I mean, you've brought up some great points, and I think the biggest thing that we want to put out there is that, frustrated business owners like me are not without options. There's things that we can do organically within our organization to start taking control of these healthcare costs, and that fires me up, because I know the money that is going out month after month after month in those increased premiums, and it's not sustainable. There's going to come a point where, as a business owner, and I'm sure you talk to a lot of business owners, that it's just not going to be sustainable. There's going to come a breaking point where, like you say in your book, it will bankrupt you. It will take over, and interestingly enough, health insurance wasn't always something that was offered by employers. There was a time when that started and just became commonplace. What other advice do you give to business owners? I don't want to be the spoiler that gives away everything in your book. I think everybody should pick up, every business owner and every consumer should pick up a copy of this book, because it's not stuff that you're hearing out there. But what are some other tidbits, without spoiling the book, that you could give to business owners like myself?
Thanks for mentioning that. And I would start by going to health-wealth.com, because you're going to see everything you want there. And if you're looking for a public speaker that will entertain you and make you laugh, but also allow you to leave with 4 or 5 points that you and your family can save money on the next day, I'd love for you to look at drjoshluke.com. But you made a point. Check out the book cover right there on top. Is healthcare bankrupting your business? Is there a better title for a book? Because the answer is yes. I don't even need to ask.
Right.
And in September, when the next book comes out that's written for the individual, is healthcare bankrupting your family? And I can tell you right now what the first line of that book is going to be. Are you an EHC? ?
Right.
And I joke with people, that's the whole book, but it's not the whole book, because we're going to give them details on how to become an engaged healthcare consumer. But the answer to your question about where should people go, what should they do, health-wealth.com has a lot of these resources. This book is going to give you a lot. We're actually going to have an interactive series up on the website pretty soon. There's a free loss assessment. You go on the website, you answer some questions, it'll tell you if your business is leaving money on the table. We'll have a similar assessment up there for families and individuals, probably by summertime before the next book launches. The bottom line is just become an engaged healthcare consumer. And if you're not prepared to buy the book yet, I'm not big on being a salesperson. I'm big on passion, and thank you for sharing that. This is personal to me.
Awesome. Give us the website one more time. We'll put it up on the screen.
So health-wealth.com is the main website with all the healthcare affordability stuff. Also, go to LinkedIn and connect with Dr. Josh Luke. And if you're interested in looking me up for speaking, which is my main income, so please do if you know somebody that might
Sure.
might be interested.
Absolutely.
Check it out at drjoshluke.com.
Fantastic. It's been great to have you today, Dr. Luke, and I hope that we can actually call upon you from time to time to come back on the show, share any new news, respond to, I'm almost certain there's going to be other companies, other corporations that are going to be getting on this bandwagon.
For sure.
And would love to hear about that in the future. So thank you, Dr. Josh Luke, for coming on Managed Care TV, and we will see you next time. Thank you very much.
My pleasure. Thank you so much.
At Care National, we are experts at recruiting medical coders for a variety of positions within reimbursement management and managed care. Our services include direct hire placement, temporary staffing, and project staffing. Each medical coder we place is screened to your company's exact specifications, including verification of coding or medical record certification by a HEMA or AAPC, employment and education verification, background for criminal or fraudulent activity. Additionally, we offer a guarantee giving you additional peace of mind for your investment in a qualified coder. Call Care National today to find a custom solution to your staffing needs. We can be reached at 1-800-974-4828, on our website at carenational.com, or simply email coders@carenational.com.
My next guest is Jim Hammond, an expert in all things healthcare here in Arizona. Jim's a healthcare consultant for his own company, Professional Healthcare Solutions, and publisher of the Hertel Report, the premier resource for the ever-changing world of healthcare. Jim, welcome to Managed Care TV.
Thank you very much for having me, Steve.
You betcha, you betcha. So just as we did with Dr. Luke, I kind of wanted to start talking a little bit about, these announcements. So now we've had Apple, we've had Disney this week. Of course, we've had Amazon, Chase, and Berkshire Hathaway last week.
Right.
What is going on?
Well, I think it's repackaging of what we've been hearing a long time, and that is employers are tired of how much they're spending on healthcare, and they want to do something about it. We've heard this before, and we do have what we call the ERISA law in our country that allows employers to build their own benefit plan, to administer it, to determine those benefits. And I think that that's getting some more play, I think, now in our industry, is that, hey, look, let's let the employers make their own decisions. Let's take this down to different levels, states, employers. We shouldn't have the government answering these questions for us. Let's answer them ourselves.
So, Dr. Luke, basically, I asked him the question, do you think these companies are going to start with, acquiring health plans? Obviously, he thinks that's the furthest from the truth. It's more or less going to start within their organizations, and initiatives that they can do within the company to start quality of care.
Sure.
That could include their own clinics. I mean, what do you think?
Well, I certainly think that them moving into providing care, to doing clinics, makes sense in certain circumstances. We're talking about a lot of employees. That's why we're talking about this, is because they represent a lot of employees. Well, are those employees all in one place? Are they all in these large offices where you could have a clinic and you can take care of people at work? Then absolutely that could be part of their solution.
Okay.
But I think the question you asked earlier is more about insurance, right? And the size. these companies are already their own insurance companies.
Okay.
They are already pooling money, paying it into either funds or
Self-insured.
they're mostly, I imagine, they're self-insured. I don't know the truth about that. Do you?
Okay. I don't. I would, as we were talking earlier, I would think with those deep of pockets that they wouldn't be handing money over to, to Blue Cross Blue Shield and United and some of those payers.
It depends on the business unit. So Berkshire Hathaway is a huge conglomerate, right? But it owns lots of companies that probably do their own thing. Some are buying fully insured products in their markets. Some are probably large enough to do self-funded.
Makes sense.
So they have a mix of these. And I think that what they're talking about is how can we, kind of combine all these things and use the leverage of all of these companies on all of these employees to get a better deal on healthcare, to get a better rate, or to get to build our own plan. And that's where I think they're eventually going to go is let's build our own plan. We can use infrastructure and technology that we have or we can acquire to do many of the functions that right now are being done by the fully insured payer.
Sure.
Or they're probably being done by a third-party administrative partner that these companies are already working with. And so will they create their own TPA, or will they push their TPA partners to do a better job? There are a number of things that they can do with this leverage.
Yeah, and it would seem to me if they're using a TPA, which most likely they are to administer
Right.
their self-funded plan, that they're probably just still getting the squeeze year after year. Hey, we got to raise your rates. We got to stay up with the times.
Sure.
That type of thing.
So they get rate increases, and what they can do to fight back with those rate increases is to have a better experience. So if you're a reinsurance carrier, you look at your client, you say, okay, hey, we're covering 1 million people, and we're only covering these events that fall out of the norm. So really, really expensive patients go to what we call reinsurance.
Okay.
And those reinsurers give out rates based on experience. So if you're a company that very rarely has any of
Right.
these events, then your reinsurance rates are going to go right down very, very quickly. They're going to go down. So that's what they want to do. They want to improve their risk experience to go buy reinsurance at a better rate. Or maybe they're big enough that they're just going to pool their own money and
Pay for
and
everything.
pay for everything.
Yeah, it would seem to me like a company like Berkshire Hathaway and Amazon, they have warehouse workers, they have, Warren Buffett owns companies that are more industrialized
Sure.
where there is higher risk for people to become injured or
Right.
sick.
Yeah, I would think that those companies are big enough to fund their own reinsurance pools. Even if they had to pay, if they're the ultimate payer, if they had to pay for 10 transplants a year, they can save the money, they can pool that money, they can put it in the stock market, right? Save that money, pool that money,
Right.
and then use it for their employees later. They're ultimately on the hook for that cost. So they can manage that at that level, but they also can lower the overall cost with this other stuff that everybody's talking about, with the wellness and the prevention. But that's not new either.
So, obviously this week has been a bad week for the stock market. I don't know if that
Right.
had any effect. I know that I have a kind of an insurance portfolio, and it took a little bit of a dip.
Sure.
How do you think ultimately these companies, big companies, going out and trying to reinventing the wheel, how is that going to affect the other traditional insurers?
Well, I'm not a wizard at making predictions, but this has happened before. I
Sure.
think these big companies, the big ones that we heard about all year, United, Cigna, Aetna, Anthem, and the Blues conglomerations, these organizations are big enough and strong enough, and they own enough market share that this should not ruin their day. This
Okay.
is not going to ruin their day. It's maybe a little bit more competition, keep them on their game. They've got to do the same thing. They've got to go to employers and say, we have the answer for you to control your costs. The old way of doing things has not worked. Our percent GDP in healthcare is going up, unstoppable. Approaching 20% of our GDP is healthcare. So insurance companies, employers have tried this stuff before. I don't think it's anything new. It's really just leverage with their size and then innovation. Are they
Okay.
going to use technology to connect with their employees to keep them from getting sick in the first place? Ultimately, prevention is the number one thing that that controls your costs.
So some of those solutions that Dr. Luke mentioned were things like telehealth,
Right.
maybe creating a confidential room within an employee center where they can go and they can actually, talk via video to a physician and get an assessment without having to go to
Sure.
a location.
These are things we already do. They're called HRAs, health risk assessment. So yeah, these health risk assessments are interviews that you can do with a nurse, and you can arrange to have these done. All 100 of your employees can go through these things, and then that helps you create programs to go identify the obese, go identify the diabetic, identify the heart risk patient, and then build wellness programs to fit their needs. This is not new. People have been trying to do this. Will these 3 big employers, or now 4 or 5 big employers, with their market leverage and their innovation, be able to come up with a new mousetrap to get this done?
We're gonna actually take a quick break,
Okay.
and then when we come back, I want to talk to you a little bit about the ACO model.
Sure.
You already kind of talked about it, value-based care.
Right.
So we'll take a quick break, and we'll be back right after this.
Okay.
Well, we're back with Jim Hammond, but before we get talking about ACOs, I just wanted to announce that we will have our next managed care TV show that will broadcast on Saturday, March 10th. Guests to be announced, but it'll be airing at 8 Pacific and 11 Eastern. So please mark your calendars or go to managedcare.tv and register for updates. So we're back talking about ACOs. There may be some people on the broadcast that don't really understand the ACO model, the Accountable Care Organization. Can you give us
Right.
the Reader's Digest version on that?
Sure. Well, people know what the ACA is.
Of course.
Right. The ACA was this huge law, and most people know about the mandate. They know about the individual mandate. A lot of people know about Medicaid expansion. That's also kind of the tip of the iceberg. But most people don't know that the ACA also started this program called the Accountable Care Organization Program. And what these are is organizations of providers. Some insurance companies got involved, but mostly it's provider organizations that have aggregated together either just physicians or physicians in hospitals, and they aggregate together and they have a deal with Medicare to take care of Medicare members and have those results tracked. And those results are tracked both on a quality basis and a cost basis.
Okay.
So Medicare is watching how much money is being spent taking care of those members. And those members are essentially assigned to one of these ACOs. So these ACOs then take the responsibility of all the costs associated with those Medicare members, and they manage it. So they start to put in processes to make sure that people stay in their network and they don't go crazy getting health care all willy-nilly anywhere across the country.
Okay.
They need to get into a case management program, and so they go and they target these people and they find out which ones are sick and they go and take care to those folks. And so they're being proactive and they're taking responsibility for the whole entire healthcare spend, and so they're starting to change the way healthcare is delivered.
So it's basically the provider is cutting out the middleman, the insurance company, and going right to Medicare for the reimbursement. Is that
Well, this is these are Medicare members, so
Okay.
they're traditional Medicare members. They do not make any choice to leave Medicare and go into a Medicare Advantage plan. So these are not
Okay.
Medicare Advantage plans. These are traditional Medicare members,
Okay.
and they can go anywhere. They have freedom to go anywhere to a doctor that takes Medicare. But what's happened is we've identified who the primary care physicians are that are mainly taking care of those people.
Okay.
And so you go to those primary care physicians and you say, hey, look, you have about 2,000 Medicare patients that are seeing you. Let's find the costly ones and let's get them into care programs, into disease management programs, so that they don't cost our country so much money.
Sure.
And then if we can save the country some money, then we'll get some of it back.
Okay.
And so there's a cost share or a risk share with these organizations where if it's demonstrated that you've met quality standards and you've lowered the cost of care, that you can get some of that. If you create some difference, some delta there, you can get a check from the federal government.
So then that's where we're talking about STARS ratings and different levels of reimbursement based on the quality of care, correct?
Well, the quality of care measures, there are 33 of them, and they're very set and they're clear. What you're talking about, the STAR ratings, are really more about Medicare Advantage plans.
Oh, okay.
And this is where a for-profit or a not-for-profit company has a deal with Medicare to sell Medicare replacement. Okay, and this is what a voucher is. When people talk about voucher programs,
system, sure.
Medicare Advantage is essentially the voucher program.
Okay.
You get essentially a voucher that says, I get regular Medicare. At very least, I get regular Medicare. You give that to Humana or Aetna or United or Cigna, and then they say, we'll give you regular Medicare plus some other stuff like vision or dental or
package
reduced.
it up.
Yeah, so they create a better benefit plan that meets the needs of that Medicare member. And those organizations, they then in turn go talk to ACOs about taking some risk and taking responsibility for bulks of those patients at a time.
Okay, so ACOs pretty much are provider-started, provider-oriented, and that's who's...
For the most part, yes, they are. There are a few main types of ACOs. There are system ACOs, so this is where you see in Arizona we have Banner Health Network, so that's a Banner owned and operated ACO. You have ACN, Arizona Care Network. Arizona Care Network is a partnership of Abrazo, owned by Tenet, as well as Dignity. They also have Phoenix Children's for commercial products join them.
Okay.
So those are system-based. Then you have a group like Commonwealth, which is purely primary care physicians that have come together, and really kind of any combination in between. You also have specialists that have created these ACOs. So you've seen one. There's a few different types, but mostly they're provider-sponsored.
Okay. Let's talk for a minute, shift gears a little bit, and talk about Medicaid, because I know that's one of your chief areas of expertise.
Yeah, Medicaid.
Arizona Medicaid is access, and it's run pretty much. There are other states that do a competitive model.
Correct.
But can you talk about what Arizona does and how that's kind of helped things here in Arizona?
Sure. Well, it kind of comes with a story. Arizona is the last state that participated with Medicaid. Okay. So we were the last state. In 1982, the Arizona State Legislature finally passed a law that said we're going to take Medicaid money. As you might know, Arizona is famous for not really wanting to take federal money, not wanting to participate in federal programs. But by the 80s, it was clear that the counties and the hospitals could no longer afford to take care of poor people and not get paid for it. So in 84 actually, they started the program, and it was all managed care. So they have a competitive bid process where for-profit companies, not-for-profit companies, government entities, anybody that wants to put together a plan can bid to win some business. And that business is capitated. You get one rate for each person, and that's all you get. So kind of a community rating for people that have different eligibility categories.
Okay.
And so it still is a very competitive process using principles of managed care for delivering public health. And then access, as we call it, became a model for other states to create these managed care models for Medicaid.
And how many other states have a similar?
I don't know specifics. I would guess that probably more than 20 states are actively using some sort of managed care model to deliver.
And a lot of them were patterned after Arizona.
Oh, absolutely. Arizona was the pioneer in this, and it's funny that consultants and people that worked in Arizona in the 80s and early 90s in Medicaid, then they went all over the country and built Medicaid programs in many other states, yes.
Let's take another very quick break, and then when we come back, I want to talk to you about your publication, the Hertel Report.
Great.
And a lot of people interested in that, so we'll be back right after this.
Excellent.
At Care National, we are experts at recruiting medical coders for a variety of positions within reimbursement management and managed care. Our services include direct hire placement, temporary staffing, and project staffing. Each medical coder we place is screened to your company's exact specifications, including verification of coding or medical record certification by a HEMA or AAPC, employment and education verification, background for criminal or fraudulent activity. Additionally, we offer a guarantee giving you additional peace of mind for your investment in a qualified coder. Call Care National today to find a custom solution to your staffing needs. We can be reached at 1-800-974-4828, on our website at carenational.com, or simply email coders@carenational.com.
All right, we're back with Jim Hammond. And Jim, you've been doing this for 30 plus years.
Right.
And I've known you from some of your State of the State addresses that you do. Tell people a little bit about what you do day to day and what the Hertel report is.
Well, I have been in the industry for 33 years, mostly in what we call the provider-payer contracting space. So I'm an expert in the contractual relationships that are negotiated and signed between insurance companies and networks and providers, hospitals, health systems, doctor groups. So I've been doing that my entire career, and in 2011 I was given the opportunity to start helping the Arizona Managed Care newsletter, which is a monthly publication that was started back in the 90s by a guy named Jim Hertel. And so eventually it became clear that I should take the company over, and I bought it from the family in 2014, and I renamed it the Hertel Report. And what our goal is we want to be the source that connects the Arizona healthcare industry. So we are where you go for news and data about healthcare, anywhere from what's going on federally with legislation and new rulemaking, those kinds of things, all the way down to our recent report about Dignity and Centene and their inability to have an in-network contract in 2018. So we cover Arizona, but we know that the national picture is really...
Keep your finger on the pulse of what's
absolutely.
going on.
We follow the national picture and then bring it into Arizona. What does this mean to you? And we pride ourselves in being impartial and forward-thinking and what we call solutions-focused. We don't dwell on failures. We're talking about what are people doing to try to change our industry and make it work more efficiently and deliver that value that we're talking about with these value-based networks.
Sure, and I know obviously we can't get your opinion on every topic, and I want to.
I have opinions
so desperately, but and I know you don't like being a speculator, but
I've been wrong a few times.
Name a couple of trends that you're seeing that is improving the value of care and any relief that you see in the future for an employer like myself.
Well, I was going to go to two things. One is this targeted case management or care management, and so these organizations that now have incentives to do so, they're mining their data to find the people in their organization, the members, the enrollees or subscribers, to find the ones that are potentially going to cost them money. And then they're intervening. They're going and saying, hey, look, you have diabetes. Let's get you in. Let's make sure you see a nephrologist. We want you to see a nephrologist. They would rather pay a nephrologist 2 times a year or 3 times a year to see somebody than to have somebody have an event, have a kidney injury.
Sure.
So I think the targeted case management where they're using technology, the EMR and claims data, because now they're partnering with the health plan, they're using data and this information from the EMR, the electronic medical record, to identify these patients that need attention. So that's one thing.
Okay.
The second one is more about what the bundled payment movement. The bundled payment movement is kind of elongating the episode and saying, you can no longer be in a silo, right? And the PCP say, oh yeah, you need to go see a surgeon, bye, go see a surgeon, and they disappear. And then the surgeon says, hey, I did what I need to do, I cut them, I closed them, I'm done. And then there's the rehab department or whatever that has to go and take the next phase and get these people back on their feet. So instead of having those all in different silos, it's one bundled payment. And now all of those players need to work together and ensure that everything all the way down to the final end of rehab is managed and controlled. And when providers start working together like that, you know what they do? They take out variation. They go and say, what were the outliers? What were the things that went wrong? And then they fix those. So they reduce variation, they reduce these outliers, they reduce the number of people that have bad outcomes. And that, I think, is really important to watch, because that will make a difference in the costs.
Yeah, I want to talk about, for a second, about co-ops. Now, this is something that's emerging. I know they're not held to the same level as far as
well, they're not ACA compliant.
Right. Well, and they're not held to the insurance laws that are out there. So, but for those people that are watching that aren't familiar with what a co-op is, what are they? Why are they a hot item right now? Pros and cons. Take it away.
Well, what I'm guessing that you're talking about are these ministry programs. Are you talking about that, right? Yeah. It's interesting. We just published a story about this on the Hertel Report just the other day. So you can go to the website, and there's a couple of stories and links to other stories about this.
Sure.
To be honest with you, I don't know a lot about it. I do know that it is not real insurance.
Okay.
You do not have guaranteed coverage,
Payments.
right?
Okay.
So it's more of a co-op of the true sense, where people are working together and they're pooling their money, and they're taking chances, basically, that nobody gets really, really sick. Okay. But if somebody gets really, really sick, they're probably not going to get their bills paid. Because those ministry organizations are pooling their money, right, for reserves. And if they have bad experience, those reserves will get eaten up and they will fail.
Right.
And so they're not held to standards about how much money you have to have reserved, or what you have to cover or not cover. So it's ripe for a problem down the road. It may sound really good now, but eventually one of these ministries is going to have a hemophiliac, or they're going to have two transplants or something like that will just delete their coffers, and then they're in trouble. So it's just like anything else. Insuring is about saving money and reserving money. And so if your ministry is reserving money and saving money, then maybe they can pull that off.
So maybe one of the positive aspects is somebody could go in, sign up for a co-op, maybe get into a doctor, routine stuff, fairly inexpensive. Maybe they have an additional catastrophic plan through another company.
Right.
But maybe they're just trying to save on the day-to-day, hey, I've got a cold, I need to go to the doctor.
Yeah, I think there are other ways to do that, and really, truly self-insurance. Why would you pay premium if you're going to pay to go to the doctor anyway? And that's the age-old quandary about insurance is, hold on a second, I could pay my own doctor bill.
Right.
I'm paying $200 a month or $800 a month in premium, but I can pay the $80. Yeah. So you're really not insuring the $80.
Okay.
You're insuring cancer. You're insuring getting hit by a truck.
Right.
That's what you're paying that money in every month for, is that catastrophic event. Paying your bills as you go, there's so many ways to do that. You can get a high deductible plan and an HSA. You could just save your money. I talk to the young people all the time. They're like, I don't want to pay $200 a month, even though you think that's a good idea. I'm like, okay, then take the $200 a month and put it in your own checking account or your own savings account, because when you get sick or when you have a diagnosis or an injury, then you have some reserves of your own, because people are saying, essentially, I want to self-insure. I can self-insure.
Yeah.
And so you say, okay, well then build some reserves, because you need to reserve if you're going to self-insure.
So in reality, though, if somebody just does that and they just tuck their $200 a month away, I mean, the thing is, by law, any emergency room has to see them.
Right.
It's really just a gambling game. Isn't that really what it's all about? For the Generation Z and the millennials?
Well, insurance is always a gamble. That's
Sure.
what you're doing. You are gambling with the health insurance company. Every time you pay your premium, you're saying, hey, here's $400. I bet I get sick.
Put it all on black.
Yeah, I bet I get sick. And then what happens? You don't get sick. You go, shoot, I just wasted $400. I keep giving them $400 and I never got sick. Well, that's good. But the opposite is bad. It's like, oh, I'm not paying, then I get sick. I saved my $400 this month, but now I have cancer.
Right. I spent it on that new BMW, and so now I don't have the money for.
So people make decisions about that all the time. But these ministries and these association health plans, which are also getting a lot of play, they're about pooling and reserving. But those organizations, in my opinion, should be buying reinsurance for those catastrophic events.
So one of the things that's been happening in our business is the consolidation or acquisition of, these larger insurance companies swallowing up, the regional players.
Right.
Are we going to continue down that road? Is there some sort of fantasy that one of these large players might get themselves into a single payer system? Or what?
I don't think that's where we're going. I don't think we'll go to single payer by consolidation. If we went to single payer, it would be through legislation.
Okay.
I don't think either of those are that likely. What I would say about this is that the companies are coming together as much as they can to get market share and to get economies of scale, just like any other industry. But I think we saw last year where the Department of Justice stands and says Aetna and Humana is too big.
They're too big. Yeah.
Cigna and Anthem is too big. And so I think anything below that, yeah, that could happen. But there's not many of those left.
Right.
So we're going to end up with 3 to 5 major players in the insurance industry. But what I think is more important to watch, and what we were talking about earlier, is these large employers or banks of employers coming together, kind of competing with those insurance companies for creating a more efficient wellness and sickness benefit plan.
Okay.
Right? You want to have a wellness plan to keep people well and to
Right.
prevent, but you have to have what we were talking about earlier, that reserve. You have to have some way to pay really big claims.
For the
And you can
catastrophic
do
stuff.
both. You can do both. And I have faith. I'm an optimist. I believe that our industry will figure out how we can do both.
Yeah, it seems like anything that disrupts the current situation is ultimately going to level out and help everybody in the long run.
Right.
Competition always helps
Drives
the consumer.
innovation.
Yeah.
Absolutely. And that's what I think this is really going to do. It puts pressure on the Uniteds and the Cignas and the Aetnas and the Anthems to do better, to be innovative, to use technology to really get at the root of the problem. Ultimately, prevention is where it's really at, and if you really care, if you're an organization that has the incentive to really care about that, then you can make a difference. Insurance companies have not had that incentive.
Right. Their incentive is basically to get the less costly care, and on the hospital side or the provider side, it's how do I make some money off this patient? How do we get, as Dr. Luke says, more heads in the bed?
More heads in beds. Well, the insurance companies, in my opinion, they measure themselves by revenue. They bonus themselves by revenue. And so it's all about growing. And so if you really want to prevent care from needing to be delivered, then you need to invest in prevention. The insurance companies do not have that incentive. They want the pie to get bigger every year. Even though they are very hard on providers and they don't want to pay providers more, every year their spend goes up, and every year their percent that they make gets bigger, right? So they're incented to have this continue.
Well, fantastic. Well, Jim, I appreciate you coming on
my
Managed
pleasure.
Care TV. Why don't you give a shout out again for your website so
Sure.
we can get it on the screen for
All right,
you?
well, it's the Hertel Report, and online it's www.thehertelreport.com. We'd love to have you come visit, and eventually, if it looks like it meets your needs, become a member and get all the good stuff behind the member wall.
Yeah, I became a member, and it's good stuff. I've already seen some of the last State of the State, which unfortunately I missed, but
Yeah.
the State of the State, if you're here in Arizona, you don't want to miss the State of the State event, and you can only be updated on that if you get involved in the Hertel Report.
Right.
And that's good stuff. That's good, solid information for anybody that's in healthcare or health insurance here in Arizona.
Well, thank you, Steve.
Thank
Appreciate
you,
that
and
testimonial.
hopefully we can have you back
Sure.
again on a future
Well,
show.
I do like to talk about healthcare. It drives me crazy sometimes, but it's my passion.
Excellent. Again, March 10th is the next Managed Care TV broadcast, starting at 8 a.m. Pacific and 11 a.m. Eastern. Hope you'll join us. We'll be announcing those guests shortly. And for now, thank you for joining us here on Managed Care TV. Have a great day.
Thanks again, Steve.
You bet.
Thanks Thanks for tuning in to this episode of the Health Wealth Podcast and Radio Show with Forbes author and contributor Dr. Josh Luke, America's Healthcare Affordability Authority. Visit drjoshluke.com for information on speaking appearances and other resources.